morning once again. Briefly, we'll be looking at overview of standard antenatal practices to prevent neonatal morbidity. It is very important. We've all heard about the statistics, and it is important that we all start preventing neonatal morbidity and mortality right from the antenatal period. And here today, I also want to emphasize on something that is equally very important, which we don't really emphasize or talked about, or most of our patients who we call guests in Limi Hospital might also want to play down, but it actually has an important role in preventing neonatal morbidity. Okay, I want us to start from one clinical scenario. I believe we have all been engaging in whether antenatal care services or neonatal services in one way or the other. And we are all familiar with different kinds of patients that have come our way along the course of practice. I have one of our guests that we have previously managed, one Mrs. Yuhe, 28-year. Thank you. One Mrs. UA, a 28-year-old gravida 3 para 1, one alive at estimated gestational age of 28 at 32 weeks, who presented with 12 hours history of drainage of fluid per vaginum. I have two questions to ask us, and I want us to respond briefly, because here this morning we are talking about preventing neonatal morbidity and mortality. What are the neonatal complications that we anticipate in this guests, in this patient, and how do we prevent? Please, I will need one or two people to please just respond. What are the neonatal complications? Please, who want to just enlighten us briefly? She's a 28-year-old gravida 3 para 1 plus 1, one alive at 32 weeks gestational age, presenting with drainage of fluid per vaginum. So what are the complications that we will anticipate?
Good morning, everyone. Okay, in this case, already we know once there is a drainage of liquor, the baby is no more protected. So you anticipate sepsis for that patient.
All right, good.
You are going to place that patient on, when you are trying to manage the drainage of liquor, you have to place the patient on antibiotics.
All right.
Then you monitor the baby, fetal heart, very important.
All right, thank you, ma. Please, are there other complications that we will anticipate in this particular patient? There are a lot of things here, and we might not be able to, discuss it in detail, but please, just briefly, from this side, please. Please, anybody to attempt? Our time is going. Yeah, thank you.
Good morning, all. The baby will experience respiratory distress.
Okay, thank you.
So as soon as the child is being, we have to initiate emergency cesarean section to enable the child to be delivered safely, and other initial care will be undergone immediately.
All right, thank you. We've had about 2 different complications to anticipate from this baby. Of course, this is a preterm baby at 32 weeks. We know that the mother is presenting with preterm prelabor rupture of membrane. We are looking at problems of prematurity. Is this baby term? Is this baby good enough to be delivered without having complications associated with prematurity? You also look at the fact that what my sister said over there, that the membrane has ruptured, the baby is not protected, the risk of ascending infection from the vagina into the uterine cavity, affecting the baby and even potentially affecting the uterus is equally there. So you are trying to balance, okay, are we delivering at this point in time? if you deliver prematurity, if you don't deliver, risk of sepsis is equally there. So looking at it, sepsis is there, antibiotics like it has been said. Risk of respiratory distress syndrome is there because at this point in time, the fetal lung has not been, is not mature yet. Surfactant is not adequately uh, produced at this point in time. So, like our team that lets the neonate breathe, this child, if delivered now, the risk of respiratory distress syndrome is high in this baby. And this particular baby will benefit from antenatal corticosteroid as much as possible if we can delay, and we can give it for over like 24 to 48 hours before we effect delivery, if delivery must be effected. Or if you want to prolong pregnancy up until 34 weeks, of course, we know that the risk of infection is there and it has to be watched out for. And I want to believe we can talk about different complications that preterm babies are at risk of. Okay, hypoglycemia is there if you deliver this baby. Hypothermia is there if you deliver this baby at this point in time. Fluid and electrolyte imbalance. Of course, because of that, this baby needs to be managed by a neonatologist, a pediatrician. It is very important in order to improve the survival rate of this baby. Okay, briefly, antenatal is a platform for important healthcare functions in the life of a family. I wouldn't want to say just a woman, because it provides us opportunity to interact with the woman, but for those who come along with their husbands, so it provides us the opportunity to see the family together. And during the antenatal period, what do we do essentially? It's a period that I call fetal-maternal surveillance. We want to optimize the health of the mother, because we know that the health of the baby, we want to have a healthy baby, you must have a healthy mother. You don't have a healthy mother, it is bound to happen that the neonatal morbidity and mortality will still increase, because that can actually increase the risk of miscarriages, preterm delivery with complication of prematurity. So it is very important, and it provides the opportunity to communicate with and support women, their family, and even the community. This is one of the things that if we continue to do, it will help us to reach out to the unreached in the community. And one of the things we do in our facility is to look beyond just the woman that we are attending to. We also want to send them to the community, those that are not coming to the hospital, so that if they have been taught, they can equally encourage others, those that will not want to access antenatal care, that are contributing to the national data that we are having. And just like Dr. Peter has said, you can imagine competing with Niger Republic, competing with Pakistan. You know, it's quite disheartening. So it's a period where we communicate with the woman, our family, and community to improve the fetal-maternal outcome. Of course, this is the care provided by you and I, especially the midwife, the obstetricians, medical officers, to pregnant women, their adolescent guests in order to ensure that their health conditions is good. The health condition of the mother and the baby is good all through the period of pregnancy. And when we look at the World Health Organization, I think in 2016, there is a guideline they provided, which is called positive pregnancy experience. And that has shown us that if a pregnant woman, has a minimum of 8 contact with healthcare professionals, it helps to reduce the risk of maternal and perinatal morbidity and mortality. Compared to those before then, it's been emphasized that, maybe focus antenatal care where you have about 4 contacts. And they discovered that the neonatal morbidity and mortality is actually higher compared to when there is a contact of at least 8 visits with the healthcare professionals, because that will help in identification of risk and in risk management. What's the aim of the antenatal? The aim is basically to ensure a healthy mother, healthy baby at the end of the pregnancy. However, like I said before, there is an alien in our environment, preconception care, because there may be some pre-existing medical, surgical, or social condition in a woman that might actually affect the baby the woman is carrying. And we all know, before most people get to know that they are pregnant, is the critical stage, the embryogenetic phase of the life of the baby. That's when who we are is laid down. And if there are medical conditions, take for example, pre-existing diabetes mellitus, of course, the baby is at risk of having congenital anomalies that can even predispose baby to intrauterine fetal death. It can even predispose, of course, baby to risk of even having to deliver baby preterm if there are other complications along the line in pregnancy. This, we are trying to ensure that women, as much as possible, those intending to get pregnant, they see healthcare professionals, their health status is optimized prior to pregnancy. The component of antenatal care basically include risk identification. After we have taken history, we have examined the woman when they come for antenatal booking. And appropriate investigation, routine investigation done. There are routine, I will quickly highlight a number of them. We need to ensure that we classify women into whether low risk or high risk obstetric population. And prevention and management of pregnancy related or concurrent diseases is part of the key things that we do. We equally do health promotion and health education. Of course, detailed history, the parity of the woman. We know that those who are, if we are talking about gram multiparous woman, there are risks that they can actually present to in the course of the antenatal. Of course, a number of them have risk of placenta previa. It can predispose to even early preterm delivery. The last menstrual period, one of the key things that has to be done at the first antenatal visit or the booking visit is to ensure we date pregnancy, because if we cannot date pregnancy, there is bound to happen that we might deliver baby preterm with the risk of with complications arising from prematurity, or there can be prolonged pregnancy. Of course, we know that increased risk of intrauterine fetal death, which we don't want. Detailed clinical examination, both general and systemic examination, holistic examination of the woman is very important to identify if there is any pre-existing condition that needs to be managed. Is very important. Routine investigation and intervention. I have this case scenario, of course, is just to talk about history taking, the importance of history. If, imagine you have Mrs. A.S., 34-year-old, gravida 5, para 2 plus 2, 2 alive, presenting for antenatal booking. So what history are we going to take? Of course, it is very important. Her age has been stated, her parity has been stated. We know that she has had 2 previous miscarriages and 2 previous delivery. We have to take history around this. And the last menstrual period is important, like I earlier mentioned, so that we prevent preterm delivery and prolonged pregnancy that are associated with a lot of neonatal morbidity and mortality. So it's very important. The events surrounding at what gestational age did she have the miscarriages is very important. Is it something that can recur? Is it something that medical intervention can actually prevent? We need to identify this. Some, it might be because of cervical insufficiency that we may need, that might require giving saccharide. We don't even know whether this woman had cervical saccharide prior in the second pregnancy that she delivered. It might be very important, that might inform us that we need to give this woman another saccharide. Then of the medical and surgical history, drug and allergy history, there are some of them that are on some treatment. Imagine you have a woman being managed for epilepsy. They might be on some medications that might actually predispose baby to congenital malformation. Obviously, if we have this history, we will know what to do. For them, they might actually need to have fetal anomaly scan at usually between 18 and 22 weeks of gestational age is very important. The examination like I said before, holistic examination, you want to examine for anemia. Anemia, of course, if there is pallor, definitely anemia has implication on the progress of pregnancy. Is a risk factor for miscarriage, is a risk factor for intrauterine growth restriction, is a risk factor for preterm delivery. Even the risk of infection in the course of pregnancy is equally there. We also want to check for jaundice, especially towards the latter part of third trimester. There is what we call cholestasis of pregnancies. There are pregnant women that can actually come down with that. Of course, if we see, and some people might equally have hepatitis and they have an acute infection. At that point in time, we can recognize pedal edema. Yes, about 7 or 8 of a pregnant woman will have pedal edema that might not be significant. However, if you are seeing that there is periorbital edema, you are having hand swelling too, it might signify that this person might be having some other conditions. Take, for example, preeclampsia in such an individual, or those who have a chronic kidney disease. The weight gain is equally very important. For those who are, of course, we know the weights. There are particular weight gain that we expect for those that are undernourished, for those that are average weight, and for those that are obese. For obese, we want a minimal weight gain, maybe between 6 to 9 or 10 kilograms all through the period of pregnancy. If you are gaining more, you know that there are risks they stand to have in the course of pregnancy. They can even deliver big babies, which also comes with its own complication. We are checking for the cardiovascular examination is very important. Yes, the incidence of cardiac disease in pregnancy is very low, but if you don't check, how do you know? Because in our environment, we don't access health care. And that is why antenatal period is a very good period to catch the people in the community, help them to improve their health-seeking status. We identify if they have pre-existing medical conditions that can be addressed, and that will improve their obstetric outcome. Of course, the respiratory system, we listen to their chest, is very important. Obstetric examination, previous surgeries, or if they are having pain in the abdomen. We check for liver. Recently in our facility, there is a guest that we are currently managing to that. We just check and we realize that, of course, she has hepatomegaly in pregnancy, and she started having jaundice too, and she's being co-managed with other specialists presently. She's improving, and we are hoping for the best obstetric outcome. What are the investigations? Definitely, Pax volume is very important. We want to know if a woman is anemic or not. This has to be addressed. Of course, it's not like I used to tell her pregnant mothers, it's not everybody that can afford some combination hematinics. Can we mention a few? Like some of them, pregnant care, this, that, and the like. It's not all the time. But what has been recommended is that if you have iron and folic acid alone might actually be important in optimizing the Pax volume of pregnant women. The blood group and rhesus factor is very important. If you don't do it, how do we know if a mother is rhesus negative? Of course, identifying the rhesus status of the woman is important, because the baby she's carrying might not have issue, but subsequent baby may end up having issue, and it can be more catastrophic. And it's very simple to get, and with the administration of anti-D immunoglobulin after delivery, if the baby she has just delivered is rhesus positive, becomes important to prevent subsequent neonatal morbidity and mortality. Genotype we want to identify. We know we are in West Africa, and the incidence of sickle cell disease is high in this part of the world. So we need to identify, because if you have a sickle cell disease mother, is an high risk pregnancy, and we need to manage them as such. Co-management will help to improve the neonatal outcome as well as the maternal outcome. To serology test HIV, hepatitis, venereal disease research laboratory, very important. Urinalysis, obstetric scan. It is important that at least a scan should be done before 24 weeks. That is the recommendation by the World Health Organization for purpose of at least dating the pregnancy, because this will help to prevent preterm delivery or prolonged pregnancy. There are other reasons why scan has to be done, but at least one should be done. If possible, between that 8 weeks and 16 weeks, we have at least a scan done. It can also help to identify the live presentation, the fetal weight, and placenta liquor volume and fetal anomaly scan. Other important tests that might be important based on the risk that we have identified. If a woman has risk of developing gestational diabetes mellitus, of course, oral glucose tolerance test becomes very important to identify, so that we can institute management to improve neonatal outcome. Fetal biophysical profile is important, especially if you have at risk mothers that are high risk in the course of the antenatal. For example, those that have severe preeclampsia, you are trying to conservate gestational diabetes mellitus is also very important, especially if you are talking about reduced perception of fetal movement. Fetal Doppler is important. Cardiotocography monitoring, non-stress test is very, very important, especially in antenatal surveillance. Vaginal swab for those who have abnormal vaginal discharge, because especially towards the end of a antenatal, it is very important if they have abnormal vaginal discharge. Some of them have there is what we call group risk streptococcus that can actually predispose a newborn to neonatal sepsis. Is important. Ophthalmia neonatorium is one of the things that they can also have. If the mother had been treated before pregnancy, it can actually reduce that. Risk identification and management. I've mentioned those high risk mothers that we may have. Of course, those with gestational diabetes mellitus, preeclampsia, eclampsia, those with previous stillbirth, those with gestational diabetes, mellitus, sickle cell disease, cardiac disorders, previous scar, multiple gestation. These are some of the high risk patients. But for those who do not have pre-existing medical condition, of course, they are classified as low risk and they are not gram multiparous, not previous scar. Now, the management. Okay. The management informs preemptive information. Whatever we have identified in the woman, we need to discuss with her. That will help her in terms of any risk identified is very important. And the progress of pregnancy, it has to be a dialogue between both the attending physician or the midwife and the patient. They need to understand before they leave the facility. Adequate balanced diet. This is very, very important. Today, people are emphasizing more on supplement than even what they eat. And it is very important. We are what we eat too. Folic acid supplementation, iron, tetanus toxoid immunoprophylaxis is very important to reduce the risk of neonatal tetanus. So please, we need to identify. And for most of our women, they are in the group of taking 22TT. Yes, we have 5 to be completed, and we need to also help them to emphasize on it so that after delivery, they can complete their tetanus toxoid immunization. Then the intermittent preventive treatment for malaria is one of the things that have been ongoing, and it's targeting preventing intrauterine growth restriction, especially from placenta parasitization, is very, very important. Before now, it used to be that you take 3 doses and you stop it by the time you are 36 weeks. But since 2012, World Health Organization has recommended that, yes, as early as possible in second trimester, you start, and a woman should take at least 3 doses. It is very important. And up until the time of delivery, that also reduces the risk of intrauterine growth restriction. Anti-D immunoglobulin, I've mentioned this. Low dose aspirin has been found to be useful in group of people that are at risk of developing preeclampsia. Is very important. And for those who have demonstrable calcium deficiency, calcium supplementation becomes important. But it's not a routine thing for all pregnant women. For those that are smoking, don't be surprised. In our community in this city, there are a group of women that smokes, those that take alcohol. They have complications that they can actually predispose some babies to intrauterine growth restriction, to preterm delivery, and the risk of prematurity, including even mental retardation. Hepatitis B immunoglobulin is equally very important for babies of mothers that are hepatitis B positive. It is very important that we give them immunoglobulin and the vaccine immediately after delivery. That reduces the risk of mother-to-child transmission that they can have. Also, for HIV positive mothers in the course of the antenatal, early introduction of antiretroviral therapy becomes important to reduce the fetal-maternal transmission of HIV, as well as post-exposure prophylaxis for their babies is important. I've talked about treatment of abnormal vaginal discharge. We also screen for asymptomatic bacteriuria. Some women don't have symptoms, but when you screen, by the time we do a urine test, you discover that they have some symptoms, some findings that will suggest that they may have a urinary tract infection. We need to screen. And some group of patients, take for example, gestational diabetic mother or pre-gestational diabetic mothers, sickle cell disease mother, HIV patient, we might need to do urine culture for a number of them. These are some of the things that we tell our patients to report immediately. They don't sit down at home and start calling the hospital. Doctor, I'm bleeding. If you are bleeding, just call. All right. That you are bleeding, but I'm on my way to the hospital if you have to. That is very important. There are danger signs. It could be as a result of antepartum hemorrhage. And also for those who have reduced perception of fetal movement, should come to the hospital. And usually we encourage that if it is not at term that you want to effect delivery, if the babies are preterm and you are thinking about whether to conserve it or not, to prolong pregnancy, it's important to admit and do a thorough antepartum fetal surveillance to prevent the risk of intrauterine fetal demise. If we need to deliver, definitely we manage as appropriate. Blood fission, headache, convulsion is a sign. All right, I'm rounding up now. Okay, I just want to ask a question before leaving the podium. The role of antenatal corticosteroid in the management of preterm babies and tocolitis is very important if there are babies that will be delivered before 34, 35 weeks of gestational age. Antenatal corticosteroid dexamethasone, 24 milligram within 24 hours, is very important to reduce the risk of respiratory distress syndrome in this baby. And we want to please encourage our So we want to encourage us to please ensure, if you're anticipating delivery before 35 weeks, to ensure that the antenatal dexamethasone is given to the mothers to reduce the risk of respiratory distress syndrome. Thank you.